So in this session, we have Dr. Navaneeth P K, who is currently working as consultant hand and microsurgeon at Malabar Medical College Hospital Research Centre, Kozhikode, Kerala. He has done his MS Ortho from Jubilee Mission Medical College and Research Institute, Thrissur, Kerala, and MCH Hand Surgery from Kasturba Medical College, Manipal, Karnataka. He has made 4 presentations at international conferences and many at national and state conferences, has 8 publications to his credit. He is a member of the Indian Society for Surgery of the Hand, Indian Orthopedic Society, Kerala and Karnataka Orthopedic Associations. He has special interests in microvascular surgery, brachial plexus surgery, congenital hand differences, tendon repair and reconstruction. And to moderate this session, we have the very famous and very passionate teacher, Dr. Tripathy, who is actually a professor at PGI Chandigarh, and he's an executive committee member in the ISSH, North Zone Association of Plastic Surgeons, Brachial Plexus Surgery Group of India, APSI, and he has been the organizing secretary of the Golden Jubilee Conference of the Indian Society for Surgery of the Hand in 2023 at Chandigarh. He has been the joint organizing secretary of the ISPNS-CON, which is the International Society for Peripheral Nerve Surgery, in 2017. And he's been a member of the organizing committee of APSICON 2014, 18, 19 and 22. Wow, that's quite impressive to see Dr. Satyaswarup Tripathy's organizational skills. He has won the NH Antia Best Publication Award by the APSI, and he has delivered the Sushruta Oration in ASI Odisha State Chapter, and he has taken the Travelling Fellowship Birmingham, UK, ISSH, Robert Ackland Fellowship in Madrid, Spain in 2025, and a recipient of the AFSH Traveling Fellowship in Boston in 2026. So it's nice to know he's been updating himself even as late as this year. He's been nice to see a person keeping on updating his knowledge. He has more than 59 indexed publications and book chapters. And today, Dr. Navaneeth is going to talk on a topic that is very commonly done surgery, that is beyond no man's land, modern concepts in Zone 2 Flexor tendon repair. Over to Dr. Satyaswarup Tripathy to take over.
Good evening, sir. It is a really nice introduction of Dr. Navaneeth. And after listening to the nice deliberation of glomus tumor, we should be going to the zone 2 flexor injury, which is a no man's land. Zone 2 flexor tendon injury was once famously described by the Bunnell, Sterling Bunnell, as no man's land because of the poor outcomes associated with the tendon repair in this region. So, however, advances in surgical techniques, magnification, suture materials, pulley preservation, and early control mobilization, they have all transformed the management of these injuries. So, today we'll discuss whether Zone 2 injury has truly become a friendly land and explore the evidences behind this modern management. Over to Dr. Navaneeth.
Thank you, sir.
Yeah.
Good evening, all. First of all, I thank GK sir for giving this opportunity and for the kind introduction. So the topic is Beyond No Man's Land, Modern Concept in Zone 2 Flexor Tendon Repair. So the evolution of Zone 2 repair starts with the great Sterling Bunnell, originally designated Flexor to Zone 2 as a no man's land due to high failure rate. However, the turning point happens when the practice of primary repair established in 1960 and later validated by the discovery of the intrinsic healing capacity of tendon. So Tang divided the Zone 2 into 4 subdivisions. That is Zone 2A, which is at the insertion of FDS, and Zone 2B, where between FDS and A2 pulley, and Zone 2C is under the A2 pulley, and 2D is proximal to A2 pulley. So coming to the biological and the biomechanical basis, the tendon get its nutrition via dual methods, that is vincular blood supply and diffusion via synovial fluid. So the vincular blood supply, you can see in this picture, vincular brevis and the vinculum longus are there. Both are supply FDS to FDP tendons through the dorsal aspect of the tendon. So and also the other there is a diffusion via synovial fluid. So these are the two nutritions that tendons are getting. So it will help in tendon healing. And the healing process is having three phases. That is inflammatory between 48 to 72 hours, fibroblastic 5 days to 4 weeks, and remodeling after 4 weeks. So tendons heal by combined intrinsic healing and with extrinsic healing. So intrinsic healing is by the inversion of tenocytes from the tendon, and the extrinsic healing by the inversion of fibroblasts from outside the tendon. So it forms a restrictive scar tissue. So early mobilization is promote more of intrinsic healing, which later reduces the adhesions and improve the quality of tendon. The goal of tendon repair is to minimize the extrinsic healing as well as to maximize the intrinsic healing process. So timing of primary repair, direct end-to-end repair is preferably between 1 to 2 weeks after the injury. And in the latest current guidelines on flexor tendon repair released in 2026 in hand surgery European journals, it is also telling that it can be extended safely up to 4 weeks after the trauma. The surgical incision, the smaller incision is preferred around 2 to 3 centimeter long, and the oblique extension of the transverse laceration either by Brunner incision or a mid-lateral exposure. And it should be only as long as to sufficient to expose the tendons. So the shorter incision obviously will lead to less post-op edema and less scarring, which will result in the gliding after the post-op repair. So how to decide to put the incision? So we can decide on the history of the patient, ask the proper history, whether it is cut in extension or it is cut in flexion. If it is cut in extension, the cut end of the tendon are close to the laceration site. By slightly flexing the IP joint, this tendon will pop out of the laceration or the tendon sheath. So if it is cut in flexion, like example like grasping a knife or a sharp object, then the then distal tendon is retracted more distally. So incision should more towards the distal side. This is how we'll decide the distal incision. And then proximal incision, if the proximal cut end is retracted back, then it can be brought into the site by either flexing the wrist and by proximal to distal milking, which help in pushing it distally. Or you can put a separate incision if it is not happening, then in the distal palm to deliver using forceps. And another way of atraumatic method is using a feeding tube, pediatric number 8 feeding tube, and which will help to retrieve the tendon. So this video showing one FPL tendon which is retrieved to the wrist, which is brought into the site using a pediatric feeding tube. So this way we can reduce the incision. So same way we can put the incision on the palm at the A1 pulley region and retrieve the tendon and retrieve to the injury site. And the repair principles include the core suture should be multi-strand. So the guideline is at least 4 strands should be required, or better a 6-strand repair is recommended. So we have different types of, most of us are using modified Kessler more commonly. So it is a 4-stranded repair with locking a link. And this is the Adelaide technique, which is also a 4-stranded technique, but it is having cruciate repair. And another one is the M-tang repair, that is a 6-strand repair using loop sutures. So repair tensile strengths on repaired tendons on various activities. This table shows that passive motion requires only 500 grams of stress. However, in active motions, it required a minimum of 1,500 grams. So when we are checking the different strands over periods of healing process, so the first week shows maximum decreasing in strength, that is 50% decrease. So if we want to start an active motion, so the minimum strength it should require more than 1,500. So the passive motion we cannot start with an 2-strand. So minimum is 4-strand, or better is a 6-strand. On repair tension, the aim of slight over tension, approximately 10% of shortening, and it results in slightly bulky repair site, approximately 20 to 30% of increasing in diameter, that effectively resists gapping under load. And the repair site become more flattened once it is under the load of active digital flexion. And it do not hamper the tendon gliding with proper pulley bending. So peripheral sutures, usually peripheral sutures are definitely required for forced hand repair. It will add the strength more, and also it will help in smooth gliding. So in a six, and there are two types of sutures, that is running suture and a crisscross locking sutures. The another way of atraumatic suturing is the putting epitendinous posterior wall first, and followed by the core suture, and then complete the anterior wall. This will avoid the turning of the tendon, and it will also prevent the vascular supply of the dorsal side of the tendon. In a six-strand repair, peripheral sutures are not required. Instead, a few separate stitches of sutures are placed to close the visible gaps between the two stems. So you can see in this M-tang suture, there is only interrupted sutures. So it is placed between the gaps. And in suture purchase, a core suture purchase of 7 to 10 mm is required from the cut end of the tendon, and the loop should be at least 2 mm in size to hold the tendon. Suture types, core sutures should be made with 3-0 or 4-0 non-braided suture, and peripheral sutures are made with 5-0 or 6-0 monofilament. And suture nodes, usually it can be at the junction of the between the tendon stems in a modified Kessler, or it can be away from the site also in another techniques. So it is the later current guideline says that the knot at the center of the repair site decreases the areas of direct contact, adding a foreign body to route of tenocyte migration, and which hinders tendon healing. So how do we manage FDS in the if it is involved? So if both FDS and FTP are injured, FDS repair is preferred. However, it is not indicated in the following conditions. That is, if it is hinders the smooth gliding of repaired FDP tendon, or if the cut is at the A2 pulley area, or the patient is presented as delayed presentation, where the tendons become more edematous. So bending of a critical pulley. The traditional teaching emphasizes strict pulley preservation, and it is now shifted to selective bending to glide the to reduce the gliding resistance. So what is the safe bending limits? A4 pulley can be entirely released, or A2 pulley can be partially bended up to 2/3. So here you can see the tendon laceration at A4 pulley. So the bending A4 pulley is completely released, and here it is at the C1 pulley, and the pulley is released to C1 and distal half of the A2 pulley. And if it's at the proximal and distal end of the A2 pulley, then distal 2/3 is released, and if it is at the middle, then proximal 2/3 is released. But however, it is decided based on the active flexion or movement of the tendon gliding. So if it is if that A2 pulleys really have a effect on the gliding, then we can then it is recommended A2 pulley can be completely released. However, it is having said that other pulleys should be intact. So a general guideline is total length of the pulley bending should be less than 2 cm with adjacent sheath intact. So either we can release a midline incision or by lateral longitudinal cut. So another important test is the digital extension flexion test. After the repair, the repaired finger is held in full extension to confirm that no gaps, and finger is moderately flexed to make sure tendon moves smoothly. So it having therapeutic value, like if the tendon is weak or loose, it is indicated by the gapping. We can revise from there itself, and it can be strengthened. And if the pulley is blocking the tendon gliding, then further bending should be required. So this is an essential quality checkpoint after the repair. So wide local WALANT is also allows the surgeons to perform it actively, the digital extension test, and we can see in this video that the tendon is moving nicely and there is no gap at the repaired site. So the WALANT, if it is possible under WALANT, it will be best to test the tendon status. Then coming to the postoperative protection exercise, there is a shift in protocol from traditional passive protocols like Cleanert and Durance to active flexion regimes with stronger repair. So the one of the active flexion protocol is the Natong protocol, where it features passive warm-up followed by partial range of true active flexion within the protective splint. So current guidelines shows 4 to 6 sections a day. Each section lasts for 15 to 20 minutes with more than 40 to 60 runs on active flexion. And full range of flexion exercises are recommended at 3 to 4 weeks after the surgery. And protective splint up to 6 weeks. So this picture, you can see the slight flexion and moderate flexion are safe during the healing process, and to avoid extreme flexion, to avoid the rupture. And if the DIP stops actively flexing if after the 3rd week, then ultrasound can be done to find the FDP is intact or not. And if it is stuck in scar, then relative motion splint can be given. So in this picture, you can see the injured finger is kept in little extension compared to the other finger, and start active movement, and it will help to get the FTP out of the scar. So this can avoid later need of tenolysis. So these are some of our results in zone 2A. Zone 2A with of middle finger, and with 2 months follow-up with full flexion. And this is another case with 2B at the index finger with full movements, and also 2C index finger with the full movements after 2.5 months. So the unavoidable complications of tendon repair is the adhesions and rupture. So if the current guidelines are followed, the tenolysis rate is decreased to less than 5%. And tenolysis performed 3 to 6 months later when there is no improvement with exercises. Active motion through full range is necessary after tenolysis, but it prone to rupture. So because of the surrounding collagen has been removed and the tendon supply has greatly decreased. So this should be explained to the patient, chance of rupture. The complication is the rupture. With the above guidelines, rupture is again can be decreased to less than 5%, and immediate repair with the previously repaired tendon is if it is ruptured. So the surgical principles and method and postoperative motions are same as primary repair. So coming to secondary reconstruction, it can be done by single stage or 2-stage. So if in single stage pre-tendon grafting, indications include it is not treated within 4 to 5 weeks after the trauma, or the defect is large and direct repair produces significant tension. And it should be most of the sheath and pulley should be intact to do the single stage grafting. So it can be considered 3 months after trauma. And in 2-stage reconstruction, indications extensive peritendinous adhesions and failure of tendon repair, like in infection cases or in crush injury cases like multiple fractures and skin damages, where the stage 1 will be pulley reconstruction over a silicone rod. You can see in this picture with this is a pulley reconstruction with the palmaris tendon graft around the phalanxes, and this is graft with suture to the remaining of the pulleys or remaining of the pulleys, and this is an FDS slip used for the reconstruction, which is again sutured to the remaining of the pulley or to the periosteum. And in stage 2, the rod is replaced with a free tendon graft after 3 months. By that time, biomembrane will be created along with the pulleys, so it will act like a synovial sheath. Another technique is the hemi-tendon transfer, either using FDS or FTP. So here the transfer of a radial or ulnar half of the profundus tendon, if you are using FDP hemi-tendon, then to reconstruct and adjust an injured profundus tendon. So advantages include only one suture site in the tendon and same anatomic and physiological properties. Early mobilization is possible and vascularized, and it is an intrasynovial graft. So you can see in this picture the FDP tendon of the middle finger is used here. So there will be two slits. One groove will be passing through the tendon. So we can split into ulnar half and radial half, and we can suture to the adjacent fingers. So this is one of our case which is done using Hemi-tendon FDP. So this patient is presented after 2 months of trauma. So on expiration, this is the distal end of the tendon, where and the proximal end is not found. It is maybe retracted to the proximal palm. And we have used the FDP of the middle finger, where we have marked the groove. You can see the two ulnar and radial slip of the FDP. So the ulnar slip, radial slip we have used, which is cut and retrieved to the palm, and then it is sutured to the distal end. And this is the 5 months follow-up video of the patient where FDP DIP is flexing, and you can see he is using the FDP also to flex the DIP of the index finger. So this is the current guideline I was talking about, and this is they are summarized nicely in a table where the previous and what are the changes from the previous to the current changes, which I already discussed over the slides. Thank you.
Dr.
Hello?
Satya, Dr.
Yeah.
Satya Swarup.
Hello. Am I audible now?
Yeah, you are.
Thank you, Dr. Navaneeth, for the nice, very nice presentation with your demonstration of your results. So
Thank you,
this
sir.
is a very you showed very with this particular surgical technique with preservation of tendon biology with robust multi-strand repairs and structured rehabilitation. You have dramatically improved the outcomes in zone 2 flexor tendon injuries. While there are still challenges like your adhesions and ruptures, but the modern principles, if you stick to them, they have certainly changed the perspectives, especially in over the zone 2 flexor tendon injuries. So they are still, we can say they are no longer they are no man's land, but rather we can say this is a region which demands precision, teamwork, and evidence-based care. So I think we should continue the discussion. There is a question in the chat box. So how do you deal with the extensor lag that is sometimes seen even when the flexion range is quite full? Dr. Navneet.
Yes, sir. So extension lag, one is we can give a Kapner splint, which will help in the passive movements, and also usually in flexor zone 2 we have not seen much extension lag in active protocols. So one option is the giving a splint is an option.
Yeah. So another question to you: when you do FDP transfer, what happens to the lumbrical muscle from where it takes origin actually?
Lumbrical muscles, actually, this is we have not gone too proximally because adjacent tendons means at the just proximal to the A1 pulley. So there we can up to there the division will be coming up to there, just proximal to the A1 pulley. So we are not going too proximally up to the lumbricals.
Dr.
So there is no
Navaneeth,
chance.
1 minute. Can you just stop sharing your screen, Dr. Navaneeth?
Oh, sure, sorry.
Yeah, you can go ahead, Dr. Tripathy.
Yeah. So is there any possibility of damage to the lumbricals?
No, sir. We didn't came across the lumbricals during our procedure.
No, why
So,
I asked, can I ask a question,
yes,
Dr. Tripathy?
yes, sir, please.
Yeah, why I asked that question was, you said there is a groove between in the FDP. You have taken
Yes,
one
yes, sir.
side, isn't it? You have split
Yes,
it
yes, sir.
nicely. Now,
Yes,
when
sir.
you split it, one half goes to the next finger, and one half continues to go to the same finger.
Yes, sir.
And the lumbrical, of course, you have not gone so proximal as to the lumbrical, but you have stopped just distal to the lumbrical. So the
Yes.
lumbrical is still acting on the same finger, isn't it? It's
Yes,
not
yes,
acting
yes.
on the next finger.
Yes, sir. Yes, sir.
Yeah, that's what I wanted to know.
Okay, okay,
Thank
okay.
you.
There is another question. The results you showed after zone 2 repair, there are very good movements. What steps that you did were responsible for the excellent results?
One is the early mobilization, sir. Early mobilization protocol within a protective splint, and definitely strong repair. We have used modified Kessler with epitendinous sutures, and with the minimal incisions. So that can definitely improve the less postopedema and less scarring, which results in the outcome as less good gliding of the tendons. So strong repair and early mobilization is the keys.
Okay. So what is your preferred core suture technique? 4-strand or 6-strand?
We are using 4 standard along with the epitendinous suture.
So
But by latest recommender, they are 6 strand is a better option. Then we can avoid epitendinous suture.
the whether it is 4-strand or 6-strand, the more important is you have to do it meticulously. That is more important.
Yes, sir. Yes, sir.
Yeah.
That is more important.
Yeah. So do you foresee epidendinous or the circumferential sutures in all the cases?
Yes, sir. All the in zone 2, especially we use for all the zone 2, we will use epitendinous sutures. Sir.
So what are the conditions where you do venting of A2 pulleys or A4 pulleys like that?
Vending, we will most of them if the single tendon is involved, we will do under WALANT only. So in WALANT, we will do active flexion extension test. Then if the tendon is gliding, so we will check the gliding of the tendon. So according to that, we will bend the pulleys.
Okay. So if there is some restriction, obviously, there is some restriction in the gliding, you have to go for this venting and opening of those pulleys.
Yes, sir. Yes.
What is the ideal timing for the primary repair?
Primary repair in the literature saying the primary repair is 24 hour, but delayed primary is 24 to 10 days. But in the guidelines up to they are telling the results are more good up to 1 month. In the current guidelines, it's up to 1 month. They are telling we can go with the primary repair.
So, when do you prefer this tendon grafting or staged reconstruction?
Staged reconstruction, if it is an the severely adhered scar, the pulleys are not sufficient enough to hold the tendons, and multiple injuries it's previously bone injury along with the skin involvement. So all these conditions, if we scar is more prone, then we'll go for secondary reconstructions. Or if it is pulleys are intact, and then we can go for single stage tendon grafting.
So in those cases, do you consider this pulley reconstruction in all the cases or in some selected cases?
No, not all the cases. Basically, which the A2 and A4 should be intact, or it should be there, so that bowstringing will be avoided. So basically, we'll check for A2 and A4 pulleys at least.
There is a question for you from Dr. Gopi. Can you elaborate an indication of FDS transfer?
Yes, sir. Indications. It's like in case of single tendon grafting, instead of we can do hemi-tendon also. So if it is in this case, the patient presented at 2 months. So if the patient is presented delayed, or in case of if we are exploring, then the gap is too long where we have to use a tendon graft. Instead, we can use this as a procedure, so that the in tendon grafting we are using repaired site, so that will add more scarring. However, this is only having single repair, which will definitely reduces the adhesions.
And moreover, it is an intrasynovial tendon.
Intrasynovial graft, and it will patient will easy to use the tendon protocol. Also, patient can easily teach, like use the other finger to
Obviously,
flex.
there'll be a question: will it not weaken the power of the donor finger?
No, sir. Actually, this single half is more than have thickness of a palmaris longest graft. So it should be enough. We have a little cases experience, but in our cases, no ruptures we have seen. And this single slip will be more than width of a palmaris longest graft.
Okay. So, which rehabilitation protocol do you prefer?
Sorry, sir.
Rehabilitation protocol after the repair.
Repair rehabilitation protocol is we will use the Natong protocol, where we will given initially we will given the within the slab we will move the patient, and we will start around 3 to 5 days to avoid to decrease the swelling, to avoid the bleeding. So, and we will start around 3 to 5 days. First, we will start with within the protective slab. We will do the passive motions by the patient itself, and then along with after the it's like a warm up exercise for the joints, and after that patient will slightly move the finger. We will not we will advise the patient not to fully grip first, initially 25% of the arc of the motion. Then we will next week we will that is increased to 50%. Then later after 3 to 4 weeks we will do full flexion motion, and up to 6 weeks we will keep the protective splint, and after that we will remove the by stage wise.
So, how frequently, and there's a question for how frequently you ask the patients to review after starting early active mobilization?
So patient has to be at least for the wound first for the wound inspection we will call the patient. We will discharge the patient around 3 to 5 days. Then every 3 days after we will call the patient to check the wound and also whether he is going correctly. And then after once the wound is healed, then it will be weekly once. Then it will be around 3 weeks. Then we will follow up for weekly up to 6 weeks. Then after 6 weeks, then 3 weeks and 6 weeks like.
When do you expect?
So depends on the improvement. If it is patient, the improvement is little slow. Some patients will have not much cooperative. Then we need to call him regularly to follow up.
When do you expect the rupture to occur?
Rupture will be maximum in first 3 weeks, sir. After that, we have not seen, and it is very rare in if it is strong repair and patient is very. I mean, it is patient is very following the protocols, means nothing to worry. But if it is patient full using the out of the skin, then full flexion, then there is a chance of rupture.
Can I ask another question, Dr. Tripathy?
Yes, sir, please.
Are you afraid, Navaneeth, are you afraid that the patient may use overpower? You said you tell the patient to use less of power while flexing. Are you scared that the patient may use too much force when doing the early mobilization?
No, sir. Usually, patient will have pain and some will be usually less aggressive than us. So they will start lightly. So we will tell them to improve to increase the flexion stage by stage.
Have you had a situation where you had to stop early active mobilization and continue immobilization?
In some patients, with pain sensitivity. So that will patient will some delay up to 5 to 7 days maximum. So within that we will always start. Some patients we have started up in early also 3 days. Minimum in 2 to 3 days. That is the early.
Is this other active mobilization is suitable for every patient?
Almost we are following here, but all the patients are following now. But otherwise, we are not facing till now any issues.
Dr. Tripathy, what is your protocol? What do you follow?
Because it's the institution setup, we can't follow up with this early active mobilization because of the caseload. So we go for this the passive mobilization protocol actually in that one.
Yeah, I agree with you, because when you start
Yes,
early
yes,
active mobilization, it
yes,
is important, as Dr. Navaneeth said,
yes,
you have to
yes,
follow up the patient every 3 days. You
Yes,
keep
yes.
coming and showing. You have to give individual. When you have a big caseload, sometimes it will be missed, and that may result in disaster for the patient, for the finger movement. So that
yeah,
way, as he says, immobilization protocol is not bad. Passive mobilization is also not bad. Of course,
yes,
early active is best because it gives the best
yeah,
results. But
yeah,
of course, the technique must have been good. If
yes.
Dr. Gopi is around, what do you feel, Dr. Gopi, about the early active mobilization?
Yes, sir. I'm here, sir.
Yeah,
Yeah, what happens is, I think in all the Western world and in the, like you said very well, that what is best for patient is a monitored, active. If you can do that, well and good, sir. Everywhere they have got out results that the passive protocol is not good, and because of our practice, and most of the senior surgeons still prefer the passive protocol. But I think it's time to change into an active protocol because it does give you good results, sir. And if in a center with good, it goes to again show that such cases should not be taken lightly and done at every hospital. It should be done in a center where there are good residents and good amount of people over there to follow up. At flexor tendon injury should not be taken very lightly. So that is the important aspect. By talking, the same topic has been, we have spoken when I was a MS, we have spoken when I was a resident, when young surgeon. I'm not so young surgeon anymore. I think it's time to kind of focus this patients to not all should do and go to centers and do it with the active because after all we all ended, we are there to give the best protocol to the patients. So this I like to highlight that importance at this juncture when there is still a question being asked about, although every study says the active protocol is better, and where still people following it, are we at the juncture where we say that they should be referred to centers with there are enough of doctors to monitor it, or should we accept it? And like many, we are all Indians, we accept many things. So should I cannot be controversial on an online proposal, but we still say that yeah, it is good. We can continue. So I think you are. I'm not that senior to say that. So I think I leave the question to open to you, sir.
see, when you have seen so many years of practice, no, you realize that some things are excellent, some things are good, and their excellent procedures must be done, excellent protocols must be followed, no doubt about that. But in a country like India, where you've got so many diverse situations, you have said send the patient to a center where you have a complete protocol and
Yes.
residence and all that. But what about the smaller areas? I mean, India is a vast country. A person after almost 100 years of, 75 years of independence, a patient must not have to travel for more than 100 kilometers to come for a tendon repair, no? So every
Yeah.
protocol, there are centers where, like Dr. Tripathi was saying, centers. I
yes,
mean, his is one of the premier institutions in the country, and
yes,
that's what I also feel, that every center has its own protocol.
Yes,
Yes,
sir.
agreed. Again, I am not doubting the results obtained with early active movements. We are all aiming towards that. Soon,
mm,
I think we'll reach that. I mean, young surgeons like Navneet are following early active mobilization
yes,
and getting good results. So good. It's
yes,
a nice change. It's a nice change that people are beginning to realize that early active mobilization must be done. Yes, it'll take some time for everybody to change.
I think that's a
Yeah.
very open and a wide answer, sir. I accept heartily because you have seen through everything. But for the young people, I'd still say don't try because it's very first surgery is the best surgery for the tendon. So either take help of a senior who has done it. If he's there, that's the best. Then he will judge you the protocol because he has seen it happening. He will be able to say he or she. I should not be he only. Matlab, the surgeon should be able to say. Senior surgeon should be able to say what is best. If we cannot consult a surgeon, young surgeons, please take it guarded. That's a very important surgery. Please send it to center or make an extra effort to talk to people and then monitor the patient rather than doing it and then sending it, sir. That's all I would like to highlight, sir.
Yeah, correct. I agree. I agree. And it was Dr. Tripathi would like to make some closing comments.
Yes, sir. It was a nice presentation, nice discussion followed by the presentation. And what I can say we can say it is no more a no man's land, zone 2 flexor tendon injury, but it is a highly demanding and highly rewarding one if done properly. So I think that will be the closing remark.
Thank you.
So over to you. Over to
Yeah.
you, sir.
So as
Yes.
Dr. Gopi was saying, no, the repair of flexor tendon in zone 2 is supposed to be the index operation of a hand surgery unit. If you have
Yes.
done 100 repairs and you have 100% results, your hand surgery unit is a really good unit. That sort of thing.
Yes.
Because it
Yes.
shows your dissection, your technique, your post-operative protocol, everything is good. And the very funny thing is, today is the 15th episode. So that means I have crossed almost 6 months. And 30 speakers have spoken. And this is the first speaker who's talking on flexor tendon zone 2 repair.
Yes.
So it shows that this is, we tend to take it very lightly sometimes, but this is a very important surgery. And Dr. Navaneeth made a very neat presentation about zone 2 repair and the results also. And he showed us also how we can achieve these good results. Very good, Navaneeth. And thank you, Dr. Tripathi, for
Thank you, sir.
moderating the session and asking the questions and discussing so that everybody here learned something new, because that is what learning is all about, no, something new every session. Thank you so much. It was a discussion about quite a common surgery, what everybody does. Still many people who are sitting in the periphery or who are working in smaller centers without guidance. And one of the points here said here may be a turning point in their surgical technique or their surgery. Thank you so much, Dr. Navneet, Dr.
Thank you, sir.
Tripathi, and of course, Dr. Sushil and Dr. Gopi. It was a wonderful session today, and we'll be meeting you again after 2 weeks. And thank you,
Yes.
Dr. Sushil. He's come, and Dr. Gopi also.
Thank
Bye,
you.
and meet you again after 2 weeks.